Welcome to The Explainer. Today, we're unraveling a truly fascinating, high-stakes detective story that is happening right now, hidden inside your own physiology. We are going to explore the incredibly precise and, honestly, sometimes volatile world of human calcium regulation. I want you to think about this for a second. What actually happens when the very electrolyte that powers every single heartbeat, fires your neurons, and literally builds your skeleton suddenly goes rogue? Well, as we're about to see, even a tiny fluctuation in your body's calcium levels can throw your entire system into life-threatening chaos. It's an unseen biochemical tightrope walk that your body has to perform every single second of the day. So here's our roadmap for today. First, we'll cover the Calcium Balancing Act. Second, when calcium drops. Third, when calcium spikes. Fourth, diagnosing calcium disorders. And finally, restoring the balance. Let's start with part 1, the Calcium Balancing Act. The master regulator at play here is parathyroid hormone, or PTH. Released by tiny glands tucked right behind your thyroid, you can think of PTH as the primary thermostat for your blood calcium. When your calcium is running low, PTH goes straight to work. First, it stimulates the osteoclasts, those are the bone-eating cells, to liberate calcium from your skeleton. It also acts on your kidneys to claw calcium back into your blood. And here's a really great way to remember its other crucial job. PTH is famously nicknamed the phosphate trashing hormone because it literally forces your kidneys to excrete phosphate just to make room for that newly freed calcium. But here's the thing, PTH doesn't work alone. It relies on this brilliant multi-organ assembly line to activate vitamin D. Step 1, your liver converts inactive vitamin D into 25-hydroxyvitamin D. Step 2, and this is where PTH plays its starring role, PTH stimulates the kidney to express a totally crucial enzyme called alpha-1 hydroxylase. This enzyme takes that vitamin D and converts it into its fully active form. Finally, in step 3, that active vitamin D travels down to your gut, plugging into calcium channels so you can actually absorb the calcium from your diet. It's just a perfectly interconnected loop. Moving on to part 2, when calcium drops. Hypocalcemia, or low calcium, creates a dangerously excitable state in the body. But what actually causes it? Well, sometimes it's iatrogenic, like the accidental removal of those parathyroid glands during neck surgeries. Other times, it's just a lack of the right building blocks. For instance, low magnesium actually paralyzes the parathyroid gland entirely, bringing PTH production to a dead stop. Or maybe a vitamin D deficiency from chronic kidney disease or malabsorption shuts down gut absorption. Then there's calcium sequestration. In acute trauma cases like rhabdomyolysis or tumor lysis syndrome, damaged cells dump massive amounts of phosphate into the blood, which violently binds up all your free calcium. And get this, even massive blood transfusions can trigger it, because the citrate used to preserve the donor blood acts like a magnet, binding up your body's calcium. The way the body reacts to that sudden drop is both brilliant and a little scary. See, calcium normally sits right around your nerves, acting kind of like a bouncer at a club, repelling positively charged sodium. Without that calcium blocking the door, sodium just rushes right into the neurons, making them wildly excitable. Clinicians actually look for 2 classic signs of this tetany. There's Schwastek's sign, where tapping the facial nerve triggers an involuntary facial spasm. And then there's Trousseau's sign, where inflating a blood pressure cuff triggers this intense, cramp-like wrist and hand flexion known as a carpal pedal spasm. Now, what's absolutely fascinating and frankly terrifying is that a patient's own panic can make all of this so much worse. If a patient starts hyperventilating, they blow off a lot of carbon dioxide, right? Well, that actually raises the blood's pH, making it more alkaline. That subtle change in electrical charge tricks a blood protein called albumin into freeing up its binding sites. So the albumin swoops in and steals whatever free calcium is left. This plummets their levels even further and triggers profound tingling around the lips and intense muscle spasms. Now for part 3, when calcium spikes. So who are the usual suspects when calcium goes too high? In an outpatient setting, it's mostly primary hyperparathyroidism, which is usually just a rogue overactive adenoma pumping out way too much PTH. But if you're in the hospital, the most common cause is malignancy. Certain lung and breast cancers secrete a fake hormone called PTH-related peptide that mimics the real thing. Other conditions like sarcoidosis or Hodgkin's lymphoma feature rogue cells that overexpress that kidney enzyme we talked about, alpha-1 hydroxylase, which skyrockets your active vitamin D. And sadly, cancers like multiple myeloma or bone metastases can directly invade the skeleton itself, using osteoclasts to ruthlessly chew right through the bone and dump all that calcium straight into the blood. When those calcium levels climb dangerously high, usually we're talking over 12 milligrams per deciliter, the systemic damage is catastrophic. To remember this widespread devastation, medical professionals have used a really famous catchy mnemonic for decades. It goes like this: stones, bones, thrones, groans, psychiatric overtones, and arrhythmia prone. Let's break down exactly what that means for a patient. Stones refers to painful calcium oxalate kidney stones, formed by all that excess calcium filtering into the urine. Bones highlights the pathological fractures and moth-eaten cysts from rampant bone breakdown. Thrones is actually super interesting. The excess calcium physically blocks your antidiuretic hormone at the kidney, causing massive water loss and sending the patient rushing to the bathroom throne constantly. Groans means intense abdominal pain from ulcers or even pancreatitis because high calcium accidentally activates digestive enzymes way too early. And since all that calcium heavily blocks sodium channels in the brain, patients suffer psychiatric overtones like profound lethargy and confusion. Finally, it makes the heart arrhythmia prone by dangerously shortening the QT interval on an EKG. Part 4. Diagnosing calcium disorders. So how do we actually play detective here? The very first step is making sure you aren't being tricked. Clinicians have to rule out pseudo-calcium disorders first by checking ionized calcium or mathematically correcting for abnormal albumin levels in the blood. If the abnormality is real, step 2 is pulling a PTH level. This is the great divider. If PTH is the one driving the chaos, it's a PTH-dependent issue. If PTH is reacting normally but the calcium is still totally off, you move to step 3, evaluating phosphate, vitamin D, and kidney function to hunt down the real culprit. To see how this works in practice, look at these two conditions. On the surface, they look identical. In primary hyperparathyroidism, a tumor pumps out PTH. Calcium is high, and because the kidneys are working perfectly, they trash the phosphate, so phosphate is low, and vitamin D is high. But over in tertiary hyperparathyroidism, which happens after prolonged chronic kidney disease, those broken kidneys can't trash phosphate or make vitamin D anymore. So even though PTH and calcium are high, phosphate is dangerously high, and vitamin D is rock bottom. The lab results tell the exact story of where the system failed. And finally, part 5, restoring the balance. For low calcium, the treatment entirely hinges on urgency. If it's just a mild outpatient drop, we simply restock the shelves, give them oral calcium and active vitamin D to prevent it from happening again. But if calcium drops below 7.5, or if the patient is symptomatic with prolonged QT intervals on their EKG, that is a massive medical emergency. You have to push IV calcium gluconate or chloride immediately to stabilize the heart muscle and prevent a fatal arrhythmia known as torsades de Pointes. Now, what if the calcium has severely spiked? We have to execute a rapid-fire treatment protocol. Step 1, flood the patient with massive IV normal saline, sometimes 3 to 6 liters of it. Remember the thrones from our mnemonic? The patient is peeing out all their water and is severely dehydrated, so the IV fluids restore volume and actively flush out that calcium. Step 2 is administering calcitonin, which works incredibly fast to shut down those bone-chewing osteoclasts. Step 3 is the long game, using drugs like bisphosphonates or denosumab to establish lasting control over bone breakdown. Once that immediate crisis is averted, long-term treatment becomes a highly targeted sniper shot, aimed exactly at the broken pathway. If low magnesium stalled the parathyroid, you simply give magnesium to restart it. If chronic kidney disease is hoarding phosphate, you give oral phosphate binders with their meals. For granulomatous diseases overproducing vitamin D, you use corticosteroids to suppress that row kidney enzyme. And if it's an overactive parathyroid gland causing the whole shebang, you surgically remove it. Or you use calcimetics. These are really clever drugs that trick the gland into thinking calcium's already high. It is truly incredible how interconnected and precise our physiology has to be just to keep us functioning every single day. Next time you feel your pulse, ask yourself, is the unseen biochemical tightrope of your body perfectly balanced today? Thank you so much for exploring the complexities of calcium disorders with me on this explainer. Keep learning, stay curious, and I'll catch you on the next one.